Hey there, thank you so much. This is Andrew Schmidt. We're going to go ahead and get started. I'm looking at the list of participants here, and it's awesome to see some familiar names there, especially from some friends across the Atlantic. But even more great is to see people I've never talked to before, so hopefully kind of get the word out as to what's important. So again, we're going to cover drowning resuscitation mainly from the pre-hospital phase, but I think this is helpful for any level of provider. As a quick introduction, I'm an emergency medicine physician at University of Florida Health in Jacksonville. There I'm also the Deputy Medical Director for Trauma 1, which is our flight program. Some other positions I hold that are pertinent to this are Medical Director for Jacksonville Beach Ocean Rescue and Medical Officer for our Volunteer Life-Saving Corps. And then my specific interest in research and teaching are drowning prevention and resuscitation. So we will be taking questions at the end. So your questions you can type in on your screen, and then at the end I'll kind of read them all out and answer each one. But if a question pops up in your head along the way, go ahead and type it out so you don't forget, and we'll get to them at the end. All right, we'll go ahead and get started. So anytime I lecture, I like to warn that I do use real-life images and videos. I think the best way to learn any type of medicine is to see what's really happening out there. So there are some graphic images which can be a little bit unsettling, but I think it's the most important way to learn this topic. So first I want to gain a historical perspective of drowning resuscitation. Anytime you talk about anything in medicine, it's very important to understand where you came from, to understand where you are today. So this first picture we're looking at is from 1237 BC, and this is the first depiction of a drowning resuscitation that we see in history. And these are from some hieroglyphs. And here, outlined in the red, you can see the guards for the king of Aleppo, who's outlined in blue. And during a battle, the king fell into a river and essentially drowned. And so his guards are trying to treat his drowning. And what they're doing is holding him upside down to try and rid the lungs of water. Again, this is the earliest depiction of a drowning resuscitation that we've seen. We start seeing some more ancient texts with different treatments. On the left side, we see holding the patient in front of a fire, the idea being that fire and smoke is a stimulant. So if you can get that person to breathe in the smoke, it might stimulate life. On the right side, we're seeing, again, holding the patient upside down, allowing the water to drain out, and also putting the patient on the back of an animal and having the animal run, essentially delivering very early forms of Heimlich maneuver and CPR. This next picture is always everyone's favorite. This is the tobacco enema, and this was used for a while in medicine. And again, the idea being that nicotine smoke is a stimulant, and how is this dead person supposed to smoke? Well, you shove a tube up their ass and you smoke for them. And this is where the term blowing smoke up someone's ass actually came from. And again, this was actually a popular treatment at one time. Here we're seeing some images from Popular Mechanics magazine back in 1946, and this is showing very early forms of CPR. If you're familiar with medical history, on the left is the Schaefer method. Essentially what they're doing is raising the ribs, causing negative intrathoracic pressure, and causing passive inhalation. On the right, for the lifeguard that had enough time and resources to build a simple machine on the beach, essentially what he's doing is rocking the patient back and forth. Again, the idea of trying to rid the body of water. A lot of people wonder why we still talk about this. Why do we study it? Why do we talk about it? We have all these fancy things. We have boats, we have robots, we got drones, helicopters, every medication you can think of. We have Lucas devices to give CPR. We have ECMO. So why the heck do we keep talking about this? Well, the problem is that an estimated 91% of worldwide drownings occur in low and middle income countries. So the problem isn't in most of the countries we're from. It's from these low and middle income countries. They don't have the resources, they don't have the education to combat this problem. So while it's not a huge deal in some of our countries, it's a huge deal around the world, and we've got to keep thinking about it and keep researching it. So what is the current global state? Well, here's where I'm going to start showing some videos. And it's important to understand that all these videos are from the last 10 or 15 years. So we're going to see some methods that may not make sense, but this is what's going on around the world. I apologize if there's a delay in the videos at all, but hopefully it's up on your screen now. So this first video that we're seeing is a child who was pulled out of the water by these military police. And the first thing to do is hold the child upside down and shake him up and down, trying to rid the lungs of water. So again, this was taken in the last 10 or 15 years and showing methods that we described originally in 1237 BC. So despite all of our advancements, despite our knowledge and technology, things that we practiced in 1237 BC are still happening today. In this next video, If you watch the full video, essentially a boat tips over about 20, 30 yards from the beach. 6 people or so drown. They're all brought onto the beach, and the very first thing people do in this community is build a fire on the beach and hold the patient upside down in the fire. And again, the idea being that smoke and fire are stimulant, that's the very first thing. They're not wrong. It's just that in their culture, that's what they've been brought to do, and they're trying to do the best for this patient. Again, seeing the same techniques we saw in the ancient text, nothing has changed. In this next video, we're seeing a small child who's pulled from a body of water. There's some police officers. And again, they're well-intentioned. They're trying to do what they think is right. First thing they do is put a child on their back and run around in a circle. And this entire video goes on for about 12 to 15 minutes of continually running in a circle, rechecking the child, putting him back on his back, and running around in a circle. I never show any of these videos to demean what these rescuers are doing. They're trying to do the right thing. I guarantee you at some point they did this and it worked and it became their standard. So you can see how dangerous stagnant protocols can be. Just because something works doesn't mean it's right. So we're trying to go for evidence-based treatments. And again, this is the exact same treatment that we're seeing in the ancient text. Nothing has changed. In this video, we're seeing very poor, low-quality CPR being done on the poolside. Again, these rescuers aren't meaning to hurt this child. They're just trying to do what they know is right. And we'll talk about CPR and the correct way to do CPR on a drowning patient, but that type of CPR that they're doing will probably have the same outcome as building that simple machine on the beach. And finally, for a little comedic relief, this is the only video I could ever find of blowing smoke up someone's ass. So luckily, we're not seeing agencies do that today. As exciting and interesting as that technique is, I can't find any evidence that anyone is still doing that. All right, so numbers. Everyone wants to know, what is the burden of disease anytime you talk about any type of disease or injury. So around the world, it's estimated about 372,000 deaths are due to drowning. It's very important to understand that this is a gross underestimate. This number does not include natural disasters, so tsunami, hurricane, tornadoes, does not include that. Does not include mass casualty, so a ferry tips over and 100, 150 people drown. That does not count. Also does not include suicides and homicides. You wouldn't think that's a big number, but in countries like Ireland, death by drowning by suicide is actually a very big problem. But none of these numbers count toward the total burden of disease. In the United States, we see about 4,000 deaths per year is the leading cause of injury death in 1 to 4-year-olds. So this does affect every age group, but it's a huge killer in 1 to 4-year-olds. And this is really the population we need to focus our treatment and prevention on. And in Florida, since we're speaking from here, it's 400 deaths per year about, again, leading cause of injury death in 1 to 4-year-olds. So once again, that pediatric group, huge burden of disease. So looking a little closer at the pediatric groups, the total number of deaths, we're looking at total death, again, 1 to 4-year-old, they have the largest burden, followed by 0 to 1, and then the older age group, 5 to 19. Looking at bathtubs, infants, 0 to 1 have the largest burden of disease when it comes to bathtub, and that makes sense. Parents put the child in the bathtub, turn around to go do something real quick, and take a little too long and come back, and the child is drowned. As we get into swimming pools, it's more the 1 to 4-year-olds, and that makes sense. I have a 1-year-old and a 3-year-old, and their job all day long is to try to get hurt. So again, that's why they call them toddlers. They toddle, and they like to walk toward the pool, and they may fall in. So we talk about swimming pools, that's 1 to 4-year-olds. And in natural water is the 5 to 19-year-olds have the largest burden of disease. And that makes sense. They're out by lakes, rivers, oceans, trying to have fun. Once we get to the older ages, we start including alcohol, and that's a huge cause of drowning death when we start getting 19, 20-year-olds. All right, so we talked about the overall burden of disease. Now we're going to talk about another topic, which is terminology. Today, I want you to walk away from this with 2 main things. I want you to understand what drowning is and isn't, and I want you to understand the primary focus of treatment of drowning. No matter what else I talk about, if you walk away with those 2 things, I've essentially done my job. So first off, we can all come up with different terms to describe drowning that we've thought of or heard of in the past. It's a very confusing topic. You probably heard near drowning, secondary drowning. Recently, dry drowning has been huge in the news. So what do these terms all mean? Well, the problem is they don't mean much. And University of Florida in Gainesville did a study back in 2006 where they looked at 60 years of drowning literature. And from that, they found 33 different definitions for drowning. That's crazy. So if you go to a primary care doc they diagnose you with diabetes, you then go to another one who has a different definition for diabetes, there's no way you can collect the right data, and you're not going to be treated properly if people have different definitions for the same disease. So because of that, in 2002, all the big minds in drowning resuscitation came together in Amsterdam and decided to come up with a standard definition for drowning to be used around the world. And this is what they came up with. There's no reason to memorize it, but I think it's important to understand what it is and that is out there and to be able to look up in the future when you're curious. And that definition is the process of experiencing respiratory impairment due to submersion or immersion in a liquid. So from that primary definition, you can have three outcomes: no injury, injury, or death. So what that says is anyone's airway who drops below the surface of the water, and because of that, they suffer respiratory impairment, they're now a drowning patient. That primary definition has nothing to do with living, nothing to do with dying. All it says is they are now a drowning patient. What this does is keep drowning within the disease process. If someone goes to die of a pneumonia, they've died of a pneumonia secondary to a drowning. So it's very important. And then the terms that we talked about earlier, like near, secondary, wet, dry, all those different terms, those are no longer used. Those are no longer actually accepted in the medical nomenclature. You see them everywhere all the time. I want you to understand that based on the international standard definition of drowning, these terms are no longer acceptable. Just as you can't be near pregnant, you can't near drown. Just as you can't have near gunshot wound, you can't near drown. Now, as I alluded to, this continues to be a big problem in our scientific literature. Every week, every month, we open up a journal and we see an article in a very high caliber journal that has the term near drowning or some term like that within the text or the title. We actually did a study last year and found that between 2010 and 2016, still about 30 to 40% of the scientific literature, peer-reviewed scientific literature, has drowning terms that were not consistent with the standard definition. So about 30% of the articles out there covering drowning within the last 5 to 6 years still have terms that are not consistent with the standard definition. That's a problem. Again, this is something that would not be acceptable, diabetes, hypertension, anything else. So something that we need to combat and make authors and researchers aware of. And outside the scientific realm, I'm sure a lot of you, especially in the U.S., heard about this supposed dry drowning case in Texas a few months ago. Essentially what happened is a small child was swimming in a body of water, had a little bit of coughing, came up, went home, and a couple days later while in bed woke up with breathing problems and died later at the hospital. Now, a well-intentioned emergency doctor that night told the family, your child died of dry drowning. Again, a term that doesn't exist in the medical nomenclature. And what he was trying to describe are kind of prolonged secondary effects to drowning. But what happened to the child didn't fit the definition at all. And I actually got the medical examiner's report, and the child died of myocarditis. So you can see how this very small piece of information, incorrect piece of information, exploded into a news story that went across our country within 48 hours. Every major news source had it. And it kind of put drowning research community back about 10 years. So again, we have to be really careful about the terms and definitions that we use with our patients. All right, so now we're going to talk about the drowning process. It is actually pretty simple and short. Every time I describe it, I try to make it even shorter and shorter because it doesn't matter how you describe drowning as long as your end result and your final step is the same. So in general, someone's airway is going to go below the water. They're going to struggle a bit. They're going to try to hold their breath, usually 30 seconds to a minute, depending on the person. At some point, the brain's going to say, dude, I need air. They're going to take a breath in. Water may or may not enter the airways. It's not important. The main thing is that you have airway obstruction because you cannot breathe through the water. And with the end result and what we need to focus on is hypoxia. Again, I don't care how you describe the drowning process as long as you understand that the final result is hypoxia. Because hypoxia is the primary cause of all systemic injury and death associated with drowning. It doesn't matter how you describe it as long as your end result is hypoxia. At the end of every talk I ever give, people always want to know, what about salt water versus fresh water? What about cold water versus warm water? I don't talk about any of those because it gets your focus away from the point. None of those things have clinical significance as long as we understand that hypoxia is our problem and what we need to combat. So we need to change our thinking. We always thought about drowning as a disease of the lungs. Everyone's worried about lungs. We can fix the lungs. If someone gets to us with a pneumonia or pulmonary edema, we can fix that. What we cannot fix is a noxic brain injury. Once the brain tissue is gone, it's gone, and we can't get it back. So we have to restructure our thinking to think about drowning as a brain injury. All right, so now onto the meat and potatoes, treatment. How are we going to treat these patients? Well, like I said, drowning and drowning disease burden and morbidity is defined by hypoxia. So we have to reverse that. So what that means is giving oxygen any way you possibly can, whether that's bag valve mask, mouth-to-mask, any pocket mask, any mouth-to-mouth if you're willing. Any way you can get oxygen to these patients, that's what you need to do first and foremost. I always like to call this my dumb slide, but I think it makes the most sense. 21 is greater than 0. So what 21 represents is the amount of air that you breathe out. The amount of air in our ambient environment. 16% is about what we breathe out. So if you can get either of those two into the patient, it's greater than 0. So people always worry about getting the oxygen hooked up, trying to get 100%, all these different things. But if you can bag that patient at 21%, or if you can give them 16% mouth-to-mouth while the equipment's being set up, it's all greater than 0. So don't worry and wait for the fancy stuff. Just start reversing that hypoxia as soon as you can. So be that person to get off the rig, to get off the helicopter, to be in the resus bay. That's bagging these patients. That's getting ventilations in these patients any way possible. This needs to be your priority of treatment. Go on to airway and breathing. Again, like I said, prioritize establishing ventilation and optimizing oxygen. That can be done in several different ways. If the patient is maintaining an airway, they can use a nasal cannula. You can use a non-rebreather mask. It all depends on the patient's mental status and condition. And really your goal for oxygen needs to be just above 95%. You can use non-invasive positive pressure ventilation, so CPAP or BiPAP. If your protocols and your experience allow for that, you can use it. There is data that says it works. It's just important to remember that if there is no rapid improvement within the first couple of minutes, you need to go ahead and proceed to endotracheal intubation. Also, CPAP and BiPAP require two things. They require the patient's breathing on their own, and mentating well enough to use the BiPAP, and also that they're protecting their own airways. So if a patient is obtunded or vomiting a lot, then CPAP or BiPAP may not be the way to go. And then finally is endotracheal intubation. Again, if anyone's looking bad or getting worse clinically, it's good to go ahead and secure the airway. This next video is going to show a very common finding in a severe drowning patient. That's a large amount of foamy material or emesis coming out of the airway. Essentially what it is, one, it is emesis or vomit. Again, the whole time the patient was drowning, they were trying to kind of save their own life and taking large gases of air. So that can be a gastric origin. Also, it is a foamaceous material that comes from the lungs. So anytime water mixes with surfactant, it causes kind of foamy material and comes out. But the main reason it's important to see this and understand what's going on is that you don't get a deer in headlights response, and that you understand, again, the focus of treatment, what you need to do. If you look at any medical textbook, any EMS textbook about material coming out of the airway before you get breaths or intubate, they're going to tell you to go ahead and suction the patient, usually 10 to 15 seconds. If it's still there, they're going to tell you to resuction the patient, 10 to 15 seconds. If it's still there, either resuction or go ahead and turn the patient on their side and try to get the material out of the airway. What we need to remember is that while we're doing all these maneuvers, the oxygen is continuing to drop, all right? The patient is not getting oxygen. They are already starting with an empty tank. So now we're dropping them more and more. So what we need to try to actually do is try to get ventilations through that material. You may not be able to, but attempt. If you can do mouth-to-mouth or use a mask or a BVM and get ventilations through that material, then you can at least start reversing the process before the rest of the treatment. And this is supported currently by the European Resuscitation Council, who tends to be a little more on the cusp than American Heart when it comes to this. Again, that's what we advocate for. If you can't get any ventilations in, great. Then you need to do maneuvers to clear the airway. But if you're able to get some breaths in, you're going to greatly improve that patient's chances of good neurologic outcome. And to hammer this point home a little bit more, we need to talk about two different cardiac arrest patients. So this guy right here in the picture, assume he's a 60-year-old dude. He's sitting at the beach, 4th round of Taco Bell, didn't take his heart medication all day long. Suddenly he just slumps back and goes pulseless. What most likely happened to him is a cardiac arrest of cardiac origin. He probably had some plaques or occlusions in his coronary arteries that finally clotted off. He's now had a heart attack because of that. That's a very different beast from the drowning cardiac arrest. A drowning cardiac arrest is a respiratory cause. You have a cardiac arrest because of a hypoxia, And because of that, these two patients need to be treated very differently. That first patient, the cardiac cause, I like to describe that his tank is full, but his engine is broken. So he had a full tank of gas, but once he clogged off his pipes, his engine seized and didn't work anymore. That's the reasons for compression AED. You have to be his engine. The gas isn't the problem. Up until the point that he had that cardiac arrest, he had a pretty good O2 set. And for that reason, they can maintain systemic oxygenation for a couple minutes afterwards. That's very different from a cardiac arrest from respiratory cause. The reason that patient's engine is broken is because they have an empty tank of gas. Most of these patients are otherwise young, healthy patients, but their heart stopped because they ran out of gas. For that reason, we have to fill their tank, and that's why ventilations take priority. I bring this up because we always hear about compression-only CPR, and it's really being pushed in the community these days. The reason for it is to increase bystander compliance with CPR and try to get more people out there doing CPR. It doesn't mean the outcomes are any better, but especially with respiratory cause of cardiac arrest, it misses the point and doesn't treat the actual problem. And this is even supported in the HA guidelines. Unfortunately, it's back on like page 800 and something. But if you look there, it says CPR for drowning victims should use the traditional ABC approach in view of the hypoxic nature of the arrest. And finally, on that topic, looking at it from a arrhythmia standpoint, again, when we talk about the older guy that collapses from cardiac arrest, the most two common causes of that arrest are VTAC and VFib. Those are shockable rhythms. That patient needs electricity and they need compressions. We talk about respiratory cause. A majority of patients who die from drowning are from PEA or asystole. And we all know that the way we treat those, we reverse the cause, which is oxygenation, and we do compressions. And moving on to circulation, you can give the patient IV fluids to avoid hypotension. Hypotension is an increased marker of mortality in drowning. Usually that hypotension is because of hypoxia, but you can also try vasopressors if refractory. There isn't a specific vasopressor to use. A couple other notes on treatment. Accidental hyperthermia, this is always brought up because people hear about that case where a person was under for 30 minutes, they came up and they're neurologically fine is because of cold water. It's important to understand that cases like that are the exception, not the rule. That's usually a very small child who falls into icy water, and because of that, they have very rapid cooling. There's submersion times up to beyond 60 minutes. There's a case report last year of a child who received 88 minutes of CPR to walk out of the hospital 3 days later. So there are pretty crazy reports like that. But again, that is usually very small children falling into icy water. The majority of drowning cardiac arrest patients who are hypothermic, they're hypothermic because of prolonged exposure. So it's not that they're in icy water, it's that they're in the water for a long time. That's actually a very poor prognostic factor. So active rewarming needs to be part of our initial resuscitation. So everyone's always wondering about cooling the patient for neurologic protection, but your initial cardiac arrest and resuscitation need to include active rewarming. Spinal immobilization, always another hot topic. Anytime I talk to EMS agencies, they all want to know, what do we do about the spine? And this is a big deal because we've seen videos, and we'll see one later in the talk, where spinal immobilization becomes the focus of treatment and people forget what they need to focus on, being reversal of hypoxia. So looking at the evidence, spinal injuries and drowning are very rare, actually. Some studies show down to 0.5%. So what we need to look for are obvious signs of trauma. So the patient who has a C-spine injury will usually have a good story of, we saw them jump off a pier, they fell from a height, or we saw them dive into the waves right before drowning, or they have obvious signs of facial or neck trauma, or they have ultramental status. Those are good signs to look for that indicate possible C-spine immobilization, but the main thing, it can't take away from your initial resuscitation. So I don't care what your evidence for C-spine is. If the patient is apneic or not breathing or in hypoxic cardiac arrest, forget the spine. You're not going to save their life by protecting the spine. You need to do your resuscitation. And next on AEDs, obviously drowning cardiac arrest is a hypoxic event. So about 85% or so of patients will have a non-shockable rhythm, being PEA or asystole. Saying that, most of these patients on beaches that are equipped with AEDs, around pools with AEDs, they will have AEDs placed. Again, the placement cannot come in front of ventilations or proper oxygenation. But it is good to know that AEDs are safe to use in the aquatic environment, in wet patients and in wet environments. We just need to make sure the pads are sticking directly to the patient's skin. So a quick towel dry and of the patient, you should be good. And then patient providers around them on wet areas are safe as well. And then there's always a question about abdominal thrust. And the reason this is unfortunately still a question is for that kind of older guy in the picture there. That's Dr. Heimlich. He recently died, but in his time as a researcher, he put out a bunch of data showing that his maneuver or abdominal thrust should be used in initial resuscitation of a drowning patient. Unfortunately, most of this data was found to be false and falsified by his own son. And it's very dangerous data because we still have agencies, especially in the water park industry, that are still following this protocol. And the protocols are saying, all right, before you do anything, do 5 abdominal thrusts. This is very dangerous for the main reason that, again, takes away from your focus of resuscitation. It delays time to that patient getting proper ventilations. Also, you go wailing on the abdomen, what are you going to do? You're going to increase the patient's chances of emesis and vomiting, and now you've complicated your airway. So again, he was the only one really advocating for this, but it's not supported by any major agency that deals with cardiac arrest or drowning, including AHA, Red Cross, Life Saving Federation, European Resuscitation Council, and American Academy of Pediatrics. They've all spoken out against using this. So this is important because you may be on scene on a beach or in a pool and have some run up and say, I'm a lifeguard, I'm a nurse. You need to do the Heimlich maneuver. You need to be able to say, no, I need you to call 911. I'll take care of this. And like I said before, spinal immobilization should not delay resuscitation. High index of suspicion for C-spine injury, you can have someone hold the head in line. But other than that, go ahead and continue with your resuscitation. So that's about it for the pre-hospital treatment. I do want to put this classification system in real quick because, again, it kind of helps us all start speaking the same language, and you're going to see it coming out more and more in the research out there. The photos of Dr. David Spielsman, one of my heroes in drowning research out of Brazil, and he was medical director for some drowning resuscitation centers down there. And essentially, he has the largest database of drowning deaths and survivors ever. So many people drowned down there in Rio, and he for years, for decades, he's been collecting this data. And what he did, took a couple thousand cases that required care from his database, this is back in '97, and made a classification system. He looked at each one, looked at their initial vital signs, initial physical exam findings, and correlated that with outcome to try to give us some sort of classification system. And he's continually updating this classification system. Like I said, you'll see it more and more in research. But essentially what a grade 1 is, that's our usual patient. I came from an ocean lifeguard background, and it's important to know that the majority of patients we pull out of the water walk away from the scene and go home without any problem. It's very rare for us to actually send someone to the hospital, at least for my beaches. Majority of them, we check them out, they're fine, they actually go home. So these are the patients, they have maybe a mild cough, they have no foamaceous material in the airway, and their lung sounds are totally clear. In his database, they had 0% mortality. So these are patients we can release with education. They may show up to the emergency department, and we'll talk about later how to dispo them. But again, very low chance of mortality. Our grades 2 to 3, a little sicker patients, we start getting abnormal lung sounds. So I say drowning shouldn't be the focus of disease in the lungs, but obviously drowning does affect the lungs. So if you're getting abnormal lung sounds in that initial exam, that's showing there's already some parenchymal damage. The patients are a little sicker. As we start getting large foam in the airway, mortality jumps up to 5%. And it's hard to tell what large or small amount of airway foam is, but if stuff starts coming out of the patient's mouth, that means they are a little bit sicker and they should probably go to the hospital for evaluation and observation. The next 3 categories are kind of a no-brainer. You start dropping your blood pressure, mortality jumps up to almost 20%. So that's a marker of hypoxia. There are other reasons for low blood pressure in drowning patients. They get an increased diuresis, but mainly that's just a marker of a sicker patient. They definitely need to go to the hospital. Obviously, respiratory arrest, very sick. Cardiac arrest, very sick. You can see in his database, patients who are cardiac arrest from drowning, 93% mortality. That's really bad. Again, what's that show? The reason they're in cardiac arrest is a lack of oxygen. So they're already starting at 0 when we get to them. So they're very, very sick patients. I'm going to show a series of short videos. These are all from the Bondi Lifeguard TV show, which at first, before I ever watched it, I thought it was going to be kind of stupid. I was a lifeguard for a long time. I always hate when TV and Hollywood try to show what lifeguards do because they're always wrong. But this actually ended up being kind of cool because it is real footage of actual lifeguards treating actual patients in the water. And what I'm going to do, I split up in 3 videos. The first one's going to be your mild, so kind of stage 1 patient. The next one's going to be your 2 or 3 category, and the last one's going to be that sick cardiac arrest patient, just so you can kind of get a sense of what lifeguards are pulling out of the water and what the patient looks like before they get to your emergency department or your ambulance.
This young girl.
So here we can see highlighted
straight into
a little child going underwater.
Raging current, probably got around 30 seconds tops to get to her before she'll start to go under.
Sorry, I think I must have cut the sound. I may have cut the sound out of these.
You go strip down, get the board, get in the water, hope you don't get
we have a rescuer going out to get the child.
Waves coming in, and then sprint to the patient.
He grabs the girl and brings her up on the board.
Okay, stay here with me.
Thank you.
I think I used close to all.
All right, so that's the end of that video. And the important thing is the video goes on to show the provider talk to the parent. The patient's acting completely normal. She's a little girl. She's talking. She's interacting. And he essentially says to the parent, hey, here's what just happened. If your child has any trouble breathing or mentating, please come back to us. But that's like your mild drowning patient. Again, the majority of people we pull out of the water, that's what they look like. They look okay. If we do an exam on them, they might be a little tachycardic because they're scared, but their blood pressure's fine, their lung sounds are fine, and we actually release them back to the family. We're looking at this next video. It's going to be, again, kind of your moderate disease of injury that we'll see here.
Maxie has just rescued 16-year-old Jason from the rip at South Bondi. He's one of a group of boys who'd been drinking illegally on the beach minutes earlier. More lifeguards back up. Oxygen will help Jason breathe if he's taken water into his lungs.
Stay awake, open your eyes for me. Good boy. You swallow any water? You swallow a lot of water.
And I swam and you just went under and you just...
Pain in the stomach? You got any pains in the stomach? In there? Yeah, Bicho, got an amber, got a male, swallowed a fair bit of water. It's one of the guys that came down, we spotted before. They've been drinking a fair bit.
With South Bondi becoming increasingly hectic, more backup is on the way.
So that patient there, kind of your moderate patient, it's a little more difficult because, like they said, he's been drinking all day. But the main thing is that kid doesn't look normal. He's kind of obtunded. It's hard for him to get a story out of him. He's having to lay down to be comfortable. He's requiring face mask oxygen. Again, that's kind of bumped him up into that moderate stage. He's not a normal walkie-talkie, I'm fine and can go home. He's kind of your moderate patient. And not the majority of patients we see, but obviously complicated by the alcohol intake. But again, just a little higher suspicion of disease. That guy should probably go to the hospital to be evaluated. And this final one we're going to see here, again, this is the drowning cardiac arrest. So obviously your most severe patient, and we'll see how the lifeguards treat that and talk about that at the end.
Flags. Copy, mate.
So if you group middle of the main set, man, quick, get there.
Do you want to meet them on the shore?
Yeah, mate, you're going to have to get there.
Chapo and Kalen are half a kilometre away at South End.
Yeah, middle of the main set. Blue Jays, can you get there? Hard to tell yet, man, but I think they got someone on the back of the ski. Yeah, can you get me the DQ, guys?
That's all right. Oi! Oi! Bring him up, oi! Hey, get him out of the water, get him out of the water. We're gonna get this, get him out of the water. Get him out of the water. Ready? And then we'll start compressions up here. Okay. Too fast.
Yeah, come on. Need a mask. Yeah, we need a mask. Okay, who's doing? I'm going on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Get the back, come on, 14, 16, 17, 19, 20. I'm just going to keep going until you get this ready. Just keep going, okay? I'm just going until...
Try and get that, get Ellen.
He's now been clinically dead for 3 minutes.
21, 22. Keep going, Chappo. Someone give Chappo a break.
Yeah, I'm 11. All right. Wait. Go.
Right, let's go.
Let's go. Wait, mate, can you... Hey, please.
Get back, mate.
Yeah, we're happy we've done this a lot of times.
Keep going, Massey. Okay, two breaths, mate. 1. Just slow down. Let's go. Pads on.
Just stop talking over, hold each other.
5, 6, 7, 8.
It's now 4 minutes since the
I'm
man was
going to
first
get a good
discovered.
airway.
No one knows how long he was under the water before then. It's critical that no one touches the man's body while it is shocked.
Get off him. I know you can't touch him. Don't touch him. You'll get electrocuted.
Then, at least 5 minutes after the man drowned,
Has he got a pulse? I've got a pulse. I have a pulse.
He's back. He's responding.
Let's go. Let's breathe.
All right, so there we saw the resuscitation, a pretty good resuscitation of a severe drowning patient. A couple of notes on it. There's 2 things I love about how these guys do it. First off, they know the focus of treatment. You can hear the guy who's running that the whole time he's running up the beach with the patient saying, I need a mask. He knows he needs to ventilate this patient and not just do compressions. The other thing I love is when the anesthesiologist keeps trying to butt in to help them, they finally say, we've done this a bunch of times, we know what we're doing. With lectures like mine and going out and learning other stuff, that's the person I want you to be on scene. I don't care what level of responder you are, from first responder all the way up to physician. You can have the same effect on a drowning patient in the field. I, as a physician, can't do anything else beyond what a first responder can do in the field, as long as you understand the focus of treatment being reversing the hypoxia. So again, if I come up on scene and you know what you're doing, you say, you go call 911. I got this. That's what I want you to understand. If you know the primary goal of treatment in a drowning patient, you can have the greatest amount of outcome, the greatest effect on their outcome. All right, so finally, the last section we're going to talk about, everyone always wants to kind of talk about prognosis, especially in the emergency department. The families wants to know what's going to happen with my child. Okay, you brought him in, you got a pulse back, now what? Do they walk out of the hospital tomorrow? Do they ever walk out? Are they going to talk to me again? The problem with this is there's terrible evidence. There's a bunch of studies out there. A couple of years ago, they finally did a systematic review on it. This is looking at data all the way from back in the 70s. Every study they looked at was graded as low level of evidence. So again, there's evidence out there, but the evidence is pretty bad. What they found and what every study that's been a good study shows us consistently is that submersion time and submersion duration is the biggest prognostic factor. And that makes sense because that correlates with the amount of hypoxia they're getting. So in general, looking at the studies, less than 10 minutes, people tend to do better. So underwater less than 10 minutes, they tend to do better. Underwater greater than 25 minutes, they tend to do pretty bad. And in between is kind of this gray zone that we don't know. Now this is tough because often we don't know submersion time. Someone might just walk by a pool and there's a kid there and they don't know how long they've been under. Parents not sure how long they turned around for. So again, we don't really know, and you can't make a big decision at the bedside, but at least tell the patient or the family, hey, you guys know he's underwater for 3 minutes. That's as good as we can ask for, kind of thing. Or you know he's under for 30 minutes. That's probably going to be pretty bad. Some other associations that were weaker were EMS response and water salinity, but those didn't have enough of a significance to even talk about. I think the most important thing to talk about is submersion duration. And things that showed no association was age, water temperature, and witnessed versus unwitnessed arrest. All right, so I'm going to wrap up here with one more video case study. It's about 6 minutes long. What I'm going to do is it's split up into 5 parts. So at certain points, a black screen will come up with some notes, and we'll talk about each thing. Usually I'd give this video and lecture in a live audience, and I can kind of talk back and forth, have a discussion. But what I want you to think about during each segment is what went well and what didn't go so well, what can be improved on, knowing, again, that hypoxia and reversal of hypoxia are the focuses of treatment. And then we'll talk about it in the end. So I'm going to pause to explain because I was just explaining it to you, but my phone was on mute. This video is from Huntington Beach a few years ago, and essentially they were filming a documentary about the lifeguards at that time on the beach, so they're able to get this footage. And it's a lifeguard, probably mid-30s. No one's really sure what happened, but pulled out of the water, presumed to be hypoxic arrest.
At least 5 or 10 minutes since we got her out of the water.
Get the resuscitator out.
Back up. Back up. Let the lifeguards do their job.
Tonight, it's pretty drastic.
Don't touch the patient. Get away.
Clear.
Set up the resuscitator. Grab the back valve mask out.
1023 the area, 2022, both Archer on the tower. Take a look.
Continue CPR.
Again, with each segment, I want you to think in your head what went well, what they could do better to improve this patient's outcome. So these are the notes I took when I originally watched the video. I think the guy who's running it actually is doing a very good job. He's pointing out providers saying, you do this, and assigning roles to everyone and getting feedback, also giving them feedback on their quality of CPR. So he's doing a very good job. The CPR, they have a good compression rate, so it's 30-2. There's no advanced airway in at this point. AED-wise, they put it on rapidly, and no shock advised. So again, if you paid attention earlier, the reason for that is because the majority of these patients are PEA or assisted arrest. So the AED is important, but it can't take priority over other things. But they didn't really stop other things to do the AED. And the main thing on this that can be done better are better ventilations. At that point, and this is the most important part of this resuscitation, the first couple minutes, they still don't have really a person dedicated to the airway. In a second, you're going to see them get a device out, a respirator that essentially is a mask, a demand mask where you push a button and it gives the patient a breath. So if you're wondering what equipment they're using, that's what it is. It hooks right to the oxygen bottle and you push the button and it gives the patient a breath.
Hey, Luke. Luke, can you hold the dog? CPR, guys. Can you hold the dog? Yeah.
All right, so now we're seeing the resuscitation continue. The guys in blue coming in, they're kind of the ALS unit. In Huntington Beach, they work with the fire department. So the ALS unit is kind of coming in, starting to do their initial evaluation and get their equipment on. The main thing I'd like to bring up here is kind of age-old stay and play versus load and go debate in EMS. This is very specific to protocols and agencies. There's plenty of agencies now going to working resuscitations completely on the beach or completely in the street, and then calling it on scene, knowing that if we don't get ROSC in the field, and that if we have PEA or systole, their chance of survival is dismal. But I think in this setting here, if you're the patient, you're the person on scene who's running this, you need to consider a load and go situation for a couple reasons. You're putting your providers in a very bad environment in terms of heat, sand. You now have a crowd of about 30 or 40 people with cameras in their face. So this is just kind of good video to show that maybe this isn't the best place to run this resuscitation. You also made the ALS crew march down the beach and bring all their equipment through the sand. That's why I preach to my guards, there's severe cases getting them back up to the station to where they can just put them in the back of the ambulance and go. Again, the pre-hospital providers can do just as good of a job as I can, but I think you can kind of improve the environment for the providers. And if you put this patient in the back of a truck and drive away, you look like a rock star no matter what. But now you're continuing to run a resuscitation on a very dead patient for the next 20 minutes or so. It may not look as well. So we're about halfway through the video, so we'll show the next segment now.
Family or friends around here of the victim? Anybody know the victim? Yes, lots and lots of salt water. Harvey?
Agent 35, he is requested. He'll be transporting back to West Service Road. He's in there. Okay,
All right, so continuing through the resuscitation, a couple things I brought up is 45 seconds without a breath. Again, understanding the problem with drowning, we still don't really have a good airway person, at least a BLS airway person. They're kind of setting up for advanced airway, but that doesn't matter. Start getting ventilation as a patient. Focus was on clearing the foam away. Like I talked about, you're not going to get that foam away. So at least trying to get ventilations in is going to be your first step, and attempt to deliver oxygen. And always have a person on the airway, okay? Basic airway, that's what we need to focus on. You also see, you may have noticed, there's one application of one piece of equipment that completely changes this resuscitation. It's kind of a fork in the road, and they diverted down one turn, which is the C-spine turn. So spinal collar was placed on this patient. And that's not right or wrong, but you can see it now puts this resuscitation down the route where spinal mobilization becomes the priority of resuscitation and not ventilations. All right, so to talk again about that same play versus load and go, again, get this patient off the beach. What was initially an exciting 2 minutes of, all right, our providers, our lifeguards got this. They're doing an awesome job. If you would put that patient in the truck and drive off, man, you look like rock stars. But now, I've cut parts out of this video. Now we're about 10 minutes into a dead guy laying on the beach, and now we're trying to intubate him. We're just, the CPR, the girl gave me CPR, looks like she's about to die. She rescued the person initially, so she is tired as can be. So some other things, we have 40-second pauses and compressions. So that airway guy, just like any of us, would be like, oh, hold on, give me 10 seconds, I can get this airway. And you keep doing that, and now you're having time off the chest, which is going to worsen their outcome and cardiac arrest. And then for me, again, better to use a back valve mask, deliver O2 and compressions, and stop the efforts to attempt intubation. Any of you have gone through a difficult airway course, that intubation should not exist. You should never be doing that intubation unless someone is entrapped and you can't move them. This guy is in a full head-to-toe BDUs. It's hot. He's in a sandy environment. He's laying on his stomach with foam and vomit coming out of the mouth, and he's trying to intubate this person. I guarantee you that's probably about a 10% success rate. And we'll see later, he thinks he got him intubated, but there's a lot of stuff coming out of the tube, and I'm wondering if he actually got him intubated. But again, get this patient in the truck, deliver basic ventilation maneuvers, and don't muck around on scene. All right, we're going to continue. We've got about a minute and a half left.
Yeah. Yeah, please. We're going to go feet first so we can manage some work in the airway. Legs.
All right, so we're going to go ahead and stop that video here and talk about the rest of the case. So what you see as a patient is no longer a drowning patient, it become a trauma patient. And that started from the second that C-collar is placed and focus is put on the C-spine, they became a trauma patient, and that became the focus of treatment. This is a dead patient getting backboarded. Dead patients should never be backboarded. It doesn't help. It doesn't bring them back to life. It only complicates things. You're now complicating already complicated airway, and now you're increasing your scene time as well. So you can see where the focus went. Like I said before, with the ET tube, that thing's just spilling out fluid. I'm not convinced the ET tube's even in the right place. So overall, I think it was a good resuscitation attempt. Again, I don't ever want to demean and Monday morning quarterback what these guys have done. If you look on the video on YouTube, there's a long discussion I've been a part of on there. And a lot of people go and try to knock what they're doing. Huntington Beach is very good lifeguards, and they're trying to do what is right. But I guarantee you in the back of their head, they don't all understand that hypoxia is what we have to reverse. I'm sure somewhere in protocol say we need to backboard drowning patients. So it all comes down to having dynamic protocols that are updated and understanding the basic pathophysiology. But otherwise, very good teamwork, very good leadership. There's just room for improvement in the actual treatment itself. So to wrap up and I'll answer some questions, 3 things. Know the terms. So know what drowning is, what drowning isn't. Someone comes up and talks to you about near drowning, a doctor, nurse, physician, family, whoever, the news, if they come talk to you about it, please do not perpetuate the problem. Please educate them on what is correct. And if you don't know, have them contact me. I'll talk to anyone. I think anyone who knows me knows that. Give me an audience, I'll talk to them. But I just want people to be educated out there so we're all speaking the same language. Reverse the hypoxia. So I think you've understood at this point that hypoxia is the beast. Hypoxia is the enemy. It's what we have to reverse to improve patient outcome. And last, think about the brain. It's not a disease of the lungs. We can fix the lungs. We cannot fix the brain. So I'm going to close out the talk and then answer some questions real quick. Drowninglit.com. This is my research website. I like to review updated research in drowning on there. And also there's access to a couple articles and systematic reviews I've done, as well as an old video lecture and a podcast all on there. And more importantly is my contact info. So again, 24/7, contact me. I'm happy to speak to you or anyone else about this. This is a passion of mine. So let's look at my notes closing out here. A couple other things real quick. We'll get to Q&A. This lecture will be available for a month. You'll receive an email from EMLRC, and they'll give you ways to access it and get your CMA credit and all that good stuff. So we have some questions here. So go ahead and add any other questions you have, and I'll try my best to answer each of them. So first off, first 2 questions are from 2 folks I really highly regard in drowning prevention. First off, Bob Pratt from up in the Great Lakes area. He asked, why is saltwater potentially better? So he's asking about that systematic review that showed possible improvement with salinity. The most important thing is the evidence on that is too weak to even make a suggestion. There are physiologic differences between salt and fresh and the amount of pulmonary edema you produce, but again, I wouldn't even regard it. I actually think about taking it out of my slides because it doesn't matter. The clinical picture is the same, the treatment is the same. If there is an effect, it would be from a physiologic and microbiologic level, but I don't think it's too important to worry about. Next one from Peter Conroy, the badass of the world, big wave surfer from Ireland. He said, can you discuss the difference in teaching of resus and drowning patients in Hawaii compared to America and Europe? So a little background on that. There's some big wave surfer courses in Hawaii. Peter has taken it actually. And the idea is that these people who are rescuing big wave surfers on jet skis and otherwise, they need to have some sort of training. And part of that is drowning resuscitation. Unfortunately, the course that is taught is completely incorrect, or mostly incorrect when it comes to drowning resuscitation, because it doesn't highlight the need for ventilations much. They also have this 10-to-1 CPR ratio. That's based on kind of a single study. I can't talk to the effectiveness of it because there's not great evidence. There's also not great evidence for 30-2, so no one actually really knows, honestly. I just got back from the World Conference on Drowning Prevention up in Vancouver, and there was one interesting talk I saw from a guy that is computer modeling, a physiologist, and had some really impressive modeling where you can essentially crunch all the numbers you can possibly think of for drowning. And the ratio he came up with from that was a 15-1, 5 initial breaths, and a 15-1 CPR to ventilation ratio. So again, that's just what he came up from a model. There's no great evidence for any of it. Whatever you do, just highlight the ventilations and just be consistent in what you do and know what the hell you're doing. My personal preference when it comes to CPR, and people ask me, is 5 ventilations up front for CPR and drowning. That's what I teach. If I came across a drowning patient today, I would give 5 initial ventilations and probably either go to 30-2 or 15-1. Just because I think most of the people who study this stuff out there would agree with me. But most of it's not based on great science. It's hard to study this stuff. It's hard to drown people with consent and then treat them. All right, Tiffany Samuel's talking about that video, said get your stuff together and go. I agree. Load and go in that situation. Get your providers out of there. Eric McMahon from Canada, he said to disregard this, but I think it's important to bring it up. He wanted to know the merits of taking time to establish an advanced airway. I think I kind of hammer this in. Yes, advanced airway may have some benefit, but don't muck around on scene, especially when an advanced airway that difficult. If you're bagging a patient, getting good chest rise, and you think they're effective, go with that, because otherwise you have hands off the chest time, you're delaying your time to get to the hospital. And you also talked about deferring vascular access and epi. I'll get on my soapbox for 10 seconds. I hope everyone understands that epi has never once ever been shown to be beneficial in cardiac arrest, especially hypoxic cardiac arrest, and there is actually evidence that it makes things worse. Yes, a lot of us use an ACLS, but never let that be your priority. I want you, again, ventilations on top of this patient before you ever think about breaking open epi for this patient. And I think I maybe have one more. Said, this is from Melody. Said, with the RLSS, that's the Royal Life Saving Society, I learned that with finding a drowning victim, we first start with 5 rescue breaths, but this year they said they should be delivered through the nose instead of the mouth. What is your view on this? So, again, this is what happens when you have terrible evidence guiding guidelines. No one knows. I mean, honestly, no one knows. Some people advocate through the nose. Some of our folks down in Brazil advocate for that as well, but no one knows. Again, just read the literature. Make sure your protocols are evidence or literature based. You're going to find different studies that say different things, but make sure you're basing on someone and you're not swinging it and not just making up as you go along. If you do that, you're going to do the most amount of good, and you realize that hypoxia needs to be reversed. No matter how you do it, you're going to do the most amount of good. So I'm going to give about 2 more minutes for any further questions that came up. I see some hands raised. I don't know if that's by accident, but if you have a question, go ahead and type it in, and I'll try to answer it for you. Otherwise, thank you guys so much for listening on this. Again, my website, you can find my contact email and phone number. Call, email anytime. I'll be happy to talk to you. But I'll just sit around and wait for any last-minute questions. So anyone else is still on, I got one more question. How do you feel about placing OG tubes alongside advanced airways and prolonged pre-hospital resuscitation efforts in drowning patients? Yes, very good. I would agree with placing it, especially in these patients. You're going to decompress the abdomen a bit. Severe drowning patients tend to have a lot of air and water in there. So if you're able to, go ahead. A lot of the King tubes now, I'm a fan of supraglottic airways or extraglottic airways. They have OG ports, so place those as well. Not the most important thing in the world, but if you have the time, especially like you said, for prolonged pre-hospital resuscitation, I don't think it would hurt. You're going to improve your cardiac return by decompressing that stomach. Another question, have studies shown any difference between pool water and freshwater ponds or lakes? So not specifically, like I said, any evidence that's on that topic is pretty weak in general. The main thing is there's no clinical difference. So like we saw in the systematic review, there is some evidence for difference between salt and freshwater, between different areas, different bodies of freshwater. Most of those studies are specific to regions. So some people will just say, maybe in an area of Japan, more people who were in pools died than were in lakes or something like that. But a lot of that has to do with availability of resources. So pools may have a higher survival rate because pools generally tend to be more public with people around them to help early. So it wouldn't so much be on the type of water itself, but the availability of a responder or medical treatment. Hope that helps. Craig said, please comment on blood pressure as it relates to drowning resuscitation. So I touched on this a little bit, but blood pressure in general low blood pressure has a higher mortality based on the Brazilian study by David Spielsman. And the main reason that these patients are just sicker. So you pull a patient out of the water, you expect them to be tachycardic hypertensive because they've been fighting for their life. But if they're hypotensive, that's not good. And that's for a couple of reasons. One is hypoxia, drops your blood pressure. You're getting cardiac dysfunction from hypoxia, drop your blood pressure. Also, you get a cold water diuresis from the renal system. A couple of reasons. Most important thing is that that's a high marker that someone should definitely go to the hospital. And this is the point where you can really help a patient. It's kind of on this treatment curve that we like to talk about, where they're on this downsloping curve. But by your treatment, you can improve that curve and kind of bring them back up to that category 2, 3, where they're not hypotensive anymore. You can give them oxygen and give them some fluids, and mainly oxygen, and actually see them turn around and get better. So just because they're hypotensive initially doesn't mean their mortality is 20%. It means that you need to treat them and try to get them back into a better category. All right, so we're going to wrap up here. I do want to answer one more question from Joe Rizzuto. She said, do you notice an increase in neurological deficit with hypothermia? So like I said, there are case studies where people with small children falling into icy water do better than those, and that's very rare. It's case studies. In terms of actual hypothermia and outcome, there's not great evidence. Like I said, most people, when they're pulled out in hypothermic, that's because they've been exposed for a long time. They actually have worse outcome usually than other people. Also, in talking about any of you who practice hospital medicine, but talking about therapeutic hypothermia, currently it's recommended to do therapeutic hypothermia if you get ROSC from the patient and hold them at 34, 35 C. The recommendation is kind of based on no evidence. So it's currently recommended just like we do with any other cardiac arrest, but there's no drowning specific evidence to say that it really works. But other than that, I do want to say thank you to everyone who is here. And yeah, contact me if you have anything. Thank you so much.
This concludes today's presentation. We thank you for your participation. You may now